The relapsed refractory Hodgkin lymphoma space has really changed in the last 10 years as well. So initially Brentuximab vedotin, the anti-CD30 antibody-drug conjugate, was approved. That was the first new drug that had been approved in over 50 years. And subsequently, I and others have helped to develop checkpoint inhibitors in this space, which have really revolutionized the care of Hodgkin lymphoma patients. So I've pioneered the combination of checkpoint inhibitors with Brentuximab, so the regimen of Brentuximab and nivolumab or ipilimumab, and that was a phase 2 clinical trial which should read out likely by next year. Additionally, there is very striking data that nivolumab and pembrolizumab, the two checkpoint inhibitors, combine very well with chemotherapy. So I think approaches are going to be really maximizing frontline therapy, the German to minimize the number of patients who relapse, and then maximizing our therapeutic strategy to really harness the synergy of checkpoint and ADC or checkpoint and chemotherapy to cure more patients. I think one question that's going to come up in the next 5 years in the relapsed Hodgkin space is that if we are better at curing patients in general, whether there are some patients potentially with low-risk disease who might be able to avoid an autologous stem cell transplant and all the toxicity that that entails, including infertility and potential damage to stem cells. So I think that's going to be an important question in the relapse space going forward in the next few years.